Hello, I'm going to be providing another update on COVID-19 therapeutics, reporting on the results of some recent clinical trials that have just been published. These are my disclosures. Today, I'm going to cover three topics: the role of baricitinib as an adjunct to the treatment of COVID-19 as studied in the ACT-2 trial, new information about COVID-19 convalescent plasma, or CCP, and emerging data on the IL-6 receptor antagonist tocilizumab. Let's start by talking about baricitinib. Baricitinib belongs to a family of Janus kinase, or JAK1 and 2 inhibitors. It inhibits intracellular signaling of various cytokines elevated in severe COVID-19. It may also inhibit SARS-CoV-2 entry by inhibiting the AP2-associated protein kinase 1. Now, you'll recall the first randomized placebo-controlled trial of remdesivir, the ACT-1 study, demonstrated a clinically significant benefit of remdesivir as compared to placebo, resulting in an approximately 3-day faster rate of recovery among patients who received remdesivir compared to the placebo. And this was in people who had been hospitalized with COVID-19 pneumonia. In the sub-analyses, it turned out that there was really not much benefit for people who were not yet receiving oxygen, and no benefit for people who were already requiring mechanical ventilatory support. And the benefit was largely demonstrated in those who were receiving oxygen to maintain adequate oxygen saturation. Now, the ACT-2 study followed quickly upon ACT-1 and attempted to build on those results by randomizing the same population, that is, adults hospitalized with COVID-19 pneumonia who had oxygen saturations of 94% or less, or required supplemental oxygen to maintain an SpO2 of 94%. They randomized them to receive either remdesivir or remdesivir plus baricitinib. And the primary endpoint was similar to that of ACT-1, the time to recovery within 28 days. Overall, as you see in panel A, the combination of baricitinib and remdesivir resulted in somewhat greater, but statistically significantly greater improvement, faster time to improvement for the participants who got the combination compared to those who received remdesivir alone. But that translated into just a 1-day improvement, which in the grand scheme of things is not a huge advance. However, looking again at the subgroups, and here the participants were divided according to ordinal scale, where the subgroup 4 were people who needed, were hospitalized but had minimal O2 requirements. Subgroup 5 were really quite similar to the group that benefited from remdesivir in ACT-1. That is, they required oxygen to maintain an SpO2 of 94%. And then subgroup 6 needed high flow oxygen, and subgroup 7 were those who were already ventilated. And what you see is that the biggest difference is really in this group that required high flow nasal cannula or other non-invasive means of ventilation, but more oxygen requirement than just low flow oxygen, and that would be the case in score 5. And so it's really this very narrow subgroup that seemed to have the greatest benefit. Here are an additional subgroup analyses. You can see that really it is in this subgroup 5, the ordinal score 6 group that the benefit is most apparent. Those with severe versus moderate disease, the severe corresponding really to a combination of 5 and 6, and then no real differences when you look across the other subcategories. So what does the US Department of Health and Human Services Guidelines panel now recommend regarding baricitinib? They still feel that there are insufficient data to recommend for or against the routine use of baricitinib in the treatment of COVID-19. Its use is recommended in combination with remdesivir in those rare patients for whom corticosteroids are contraindicated or where steroids cannot be used. They note that because of the way in which the data were developed, baricitinib should not be used without remdesivir because there's no benefit that there's no evidence that it has benefit on its own. And there are insufficient data to recommend for or against the use of baricitinib in combination with corticosteroids. Now, there is an Act 3 trial that is ongoing, which is comparing remdesivir baricitinib to remdesivir with dexamethasone. But I frankly have problems with that trial because we know that dexamethasone is life-saving. And so for those randomized to the remdesivir baricitinib arm, they're actually deprived of potentially life-saving therapy. Well, let's turn to an update on COVID-19 convalescent plasma. As you'll recall, convalescent plasma from survivors of COVID-19 may contain high titers of neutralizing antibody. It's essentially obtained by pheresis of those who have already survived and are now once again healthy after recovering from COVID-19. And the plasma could be used either as post-exposure prophylaxis or to treat individuals who have active symptomatic disease. CCP, convalescent plasma, has been shown to have some benefit in the treatment of avian influenza and H1N1 influenza, as well as MERS. And pilot studies and data that we've reviewed on previous programs in this series have shown some possible benefit of CCP, or COVID-19 convalescent plasma. These are the previous data from Joyner and colleagues at the Mayo Clinic, analysis of data from more than 35,000 people in the United States who received CCP as part of an expanded access program. Note that half of them were already in the ICU and more than a quarter were intubated. And this is not a randomized trial. This is a comparison of those who received early versus late therapy and those who received low versus high, medium or high dose therapy. The dose here meaning not dose exactly, but titer. That is, these plasmas were later determined to have low, medium, or high titers of neutralizing antibody. And those who received high titer antibody and who received it within 3 days had the greatest benefit compared to those who received low titer CCP or those who received antibody after several days. Just yesterday, the New England Journal of Medicine published a study, results of an analysis of a subgroup of those 35,000, 3,000 participants who received CCP prior to July 4th of last year now, and showed that there was a lower risk of death if you compared the high dose group, or I keep saying dose, but high titer group to the low titer group among non-intubated participants. And that was about a 1/3 reduction, a relative risk of 0.66. You can see the confidence intervals exclude 1. In the forest plots shown on the right here, some of the details are hard to see perhaps on your screens, but essentially looking at people who received treatment before or after May 15th, divided by age group, and then whether they were or were not mechanically ventilated. You can see comparing medium titer antibody to low titer antibody levels, there was really a very scant difference. Not just about a 10% improvement, but that was not statistically significant. But then if you compare the high titer plasma to low titer plasma, there you see there was about a 20% improvement or lower risk of mortality among those receiving high titer antibody, and that was statistically significant across all groups, and better in the non-ventilated than in the ventilated patients. Now, those data need to be placed in contrast to the Plasmare study, which we've previously reported. This was a placebo-controlled randomized trial of CCP for COVID-19 conducted in Argentina. 334 participants were randomized 2-to-1 to receive CCP versus placebo. These plasma units had a mean IgG antibody titer of 1 to 32,000. All had titers greater than 1 to 800, but these are antibody titers, not necessarily neutralizing titers. And the median time to symptom onset in this group of patients was 8 days. Nearly all were receiving supplemental oxygen, and again, the vast majority were receiving corticosteroids. And the primary endpoint was the distribution of outcomes using the ordinal scale with which we've become so familiar at day 30. And here are those results. You can see the top pair of bars shows the primary endpoint, the distribution of outcomes 30 days after the intervention. And there's really a very little difference. Perhaps in this category of discharge without full recovery, there are a few more participants who ended up there compared to the placebo. Really no difference in mortality, no difference in invasive ventilatory support. And so the distribution overall is not statistically significantly different. Earlier on, there seemed to be perhaps a slight advantage of CCP versus the control for early mortality at days 7 and 14, but these were not the primary endpoint and they didn't achieve significance. That should be placed in contrast to this more recent study, also published in the last week or so in the New England Journal of Medicine from the Fondation Enfant COVID-19 study. This was another randomized placebo-controlled double-blind trial of CCP versus placebo. All the CCP units had high titer SARS-CoV-2 IgG, again, not tested initially for the neutralization titer, just the antibody titer. This study focused on older individuals, patients who were 75 years or older, or those 65 and older with at least one comorbidity among the traditional comorbidities now that we've come to recognize as placing people at greater risk of disease progression. They had to have symptomatic PCR-confirmed SARS-CoV-2 infection. They were excluded if they had severe COVID-19, defined as a oxygen saturation of less than 93%. The primary endpoint was the development of severe respiratory disease through day 15. 160 participants were enrolled, and curiously, especially in retrospect now, this study was halted after just about 3/4 of the participants projected to enroll had been accrued because the local prevalence of COVID-19 had fallen so much they couldn't complete enrollment. I suspect had the study continued, they would now be able to finish it. What the study showed is that in terms of preventing progression to severe disease, there was about a 48% reduction in risk. You see the relative risk is 0.52 for progression for the convalescent plasma group compared to the placebo group. And then in looking at the Kaplan-Meier distribution of time to being time spent free of severe respiratory disease, you see that there was a more rapid progression in the placebo group compared to the convalescent plasma group. So some studies in favor and some studies against the use of convalescent plasma, depending on exactly which patient groups are being studied and exactly when the intervention is given and what the quality of the CCP is. So anecdotal evidence and uncontrolled trials suggest convalescent plasma may provide a benefit in patients with severe COVID-19. The benefit appears related to early administration of high titer plasma. There's little or no benefit in critically ill or intubated patients. And there have been mixed results, as you've seen to date from the randomized trials, although there are still several additional trials ongoing. As a consequence, the US Department of Health and Human Services COVID-19 Treatment Guidelines panel states that there are still insufficient data to recommend either for or against the use of convalescent plasma for the treatment of COVID-19. Convalescent plasma should not be considered standard of care for the treatment of such patients at this time. Well, let's finish with a discussion of tocilizumab. Tocilizumab is one of several agents, all monoclonal antibodies, that interfere with the IL-6 receptor axis, either by blocking the receptor itself or by binding to interleukin-6. And when blocking this pathway, they prevent signal transduction that would ordinarily lead to an inflammatory storm, and therefore hoping to calm the cytokine storm that characterizes the later phases of COVID-19 disease. Now, there have been several meta-analyses looking at different studies, both observational and randomized clinical trials of tocilizumab, and I just highlight this one particular study published several months ago in clinical microbiology and infectious diseases because it focuses on the randomized trials. And what you can see is looking at these 5 trials where for the mortality endpoint, there's really no obvious benefit of tocilizumab. However, looking at the secondary endpoint of preventing progression to mechanical ventilation, there does seem to be a potential benefit of about a 30% reduction in the risk ratio for participants who received tocilizumab compared to control. Now, most recently, just a week ago, investigators from the Remap Cap Study posted results of their trial as a non-peer-reviewed preprint on medRxiv. The Remap Cap Study, very much like the recovery trial, was an adaptive randomized trial, this one in critically ill patients admitted to the ICU and receiving respiratory or cardiovascular organ support, meaning the ventilated or on ECMO. These were, and this particular part of the study focused on the immune modulation therapy domain, which could include one of several different agents: tocilizumab, sarilumab, anakinra, which is an IL-1 receptor antagonist, interferon beta 1 alpha, and control. The way in which the study was done is investigators decided which agent did they want the participant to be eligible for. So you could be randomized to tocilizumab or control, anakinra or control, and so on. And not all the agents were available at the same time, and not all agents were available at all centers. The primary outcome was respiratory and cardiovascular organ support-free days up to day 21. So how many days after enrollment did you remain free of needing to be on a ventilator or on ECMO and the like? And it used Bayesian cumulative logistic models using a neutral prior distribution, and I'll explain that in a minute, to determine the probability of superiority of the intervention. Randomization ended on the 19th of November for tocilizumab and sarilumab after a safety monitoring board analysis found significant evidence of a tocilizumab benefit. There were just under 900 participants randomized in the immune modulation domain at that point, about 370 to tocilizumab, just under 50 to sarilumab, 400 plus to the control, and 70 to other interventions in that group. About 30% were receiving mechanical ventilation at entry, and roughly 90% were receiving corticosteroids, which is an important difference between this study and some of the earlier tocilizumab studies done before data from the recovery trial had become available. What this study showed is that for the primary outcome of, then this is the distribution of endpoints and the cumulative proportion of patients with the organ support-free days, what you can find is that the tocilizumab group and the sarilumab group both spent more time free of organ support compared to those who received the placebo. You can see the odds ratios here, and then this is where the Bayesian statistics comes in. The probability of these differences being correct is greater than 99%. So that is the posterior probability where just finding a difference is the neutral posterior probability. And then looking at the distribution of days spent free, -1 represents death. And so you can see that there were about 35% of those in the control group who died, 22% in the sarilumab group, and 28% in the tocilizumab group. So if we now look at survival, you see that both tocilizumab and sarilumab had significantly greater odds ratios of survival, 60% and double respectively compared to the control, and the posterior probability of these differences being significant again exceeds 99%. So where does this leave us with tocilizumab? Well, the Remap Cap study demonstrates significant benefit, including a survival benefit for tocilizumab and for sarilumab, but there were a very small number of participants in that arm, and so those data are much more provisional. And remember that this is limited to critically ill patients, all of whom are also receiving corticosteroids. On the basis of these data, the UK authorities now authorize the use of tocilizumab, ideally in combination with corticosteroids. The US Department of Health and Human Services Guidelines panel has yet to re-review the tocilizumab. The recommendations they have issued were last updated in August of 2020, and therefore those guidelines continue to advise against its use. Thank you very much for listening to this summary and update.